So today we're going to talk about childbirth, not so much pregnancy, but definitely emergency childbirth. So the thing is, most deliveries happen at the hospital or a birthing center, but if it's, and if it's a first time pregnancy, they'll probably have enough time to get to the hospital, but sometimes women might have had several children and the deliveries get faster with each child, or they may be far away from a hospital. Like in our area, we have a hospital that serves a very large area, and so sometimes with travel time or with weather, there might be a reason for them not to make it all the way to the hospital. And in that case, if once the child is on its way, there's no stopping that. So it's more likely in a rural area to have to assist with an emergency childbirth, much more likely than in an urban area. So what really matters on this is that you understand that, and really for emergency childbirth to go well, there's sometimes you can't control all the different things going on, but babies have been born for a very long time. I know that my grandmother told me once that, when she was having kids, they just really kind of gave them a sedative and let the baby be delivered on its own. So in assisting, there's a few things you'll do, but mostly just to know what's normal and what's not normal, and a few things that you should do. You should have a pretty good outcome, assuming that the baby is full term. So that's really kind of what's important on this slide, is that one, there's a few things that are different. There's the amniotic sac and the amniotic fluid and the placenta and the umbilical cord. This is all new stuff that will eventually be birthed along with the infant, or after the infant, technically. And then, technically, some of it's before the infant, then the infant, and some of the stuff comes after the infant, but we'll get to that in a minute. And then down here is important. A normal pregnancy is 40 weeks. Women will tell how far along they are in weeks. It's good to know that 37 weeks is when the baby is fully developed. In those last 3 weeks, it's really fattening up, but the lungs have finished. And so if it's a first-time mom and the baby's coming early, she might be very panicked, but you can comfort her by saying that, if she said, I'm 38 weeks, the baby's 2 weeks early, and she's very scared, you can tell her that 37 weeks, the baby is fully developed, lungs will be working. It's not even considered premature at that point. Now, if you find out that she's much earlier than that, let's say, really, depending on the hospital, sometimes in better hospitals, they can go as early as 22 or 21 weeks. But really 23, 24 weeks is the point of viability, meaning that prior to that, there's not much that even doctors could do to help save the infant. Just it's not developed enough to live outside of the womb. So now this you wouldn't tell the mother if she said, I'm 20 weeks. But you wouldn't tell her that no, that infant's not going to live if it's born outside the hospital, and maybe not even going to live even if it is born in the hospital. But that's good for you to know, that situation is probably an infant's going to be delivered that's not alive, or alive for just a little bit of time. And then if it's, say, 30 weeks, you really need advanced medical care as soon as possible, because that infant will need immediate intensive care, because it would be 10 weeks early. But I have a niece who was born 10 weeks early at 30 weeks, and she's wonderful and fit and plays all kinds of sports. But yes, she did need intensive care for several weeks while in the hospital. So labor and delivery usually takes about 12 to 24 hours, depending on which pregnancy it is. Now that's the whole thing. That's not just pushing. You don't push. Well, I have heard of people having to push for over 12 hours, but usually when I'm talking about labor and delivery, it's everything from the contractions that help the cervix get ready, to the delivery, to the afterbirth. Again, we'll get to all of this in a second. So The infant is what basically decides when it's time to be born. It secretes signaling molecules that start the contractions. Now, sometimes women can be headed to the hospital because they think they're in labor, but they're not actually in labor. And one of the things you can tell the difference between Braxton Hicks, which is false labor, it's really just the uterus getting ready and preparing for delivery, and real delivery is how regular the contractions are. So if the contractions are 3 minutes apart, then 2 minutes apart, then 4 minutes apart, then nothing for 10 minutes, and then two in a row, that would be Braxton Hicks. True labor is coming at a regular interval, annual, and then slowly speeding up, but it wouldn't get longer in between. All right, so there's 3 stages of labor. In stage 1 is the development of the cervix. So the cervix is at the top of the vagina, and it remains closed to keep the baby inside, which is important. And then on top of the cervix, inside the womb, there is something called a mucus plug. Yes, I just said mucus plug. And so this basically is like a plug, a cap to keep anything from moving in and out of the womb. It keeps the baby from getting an infection and bacteria from getting inside. So that's also very important. But as the cervix starts to dilate and prepare for the delivery of the infant, it opens. And when it opens, the mucus plug will pass through and will basically be delivered. And so it can be a decent size mucus plug, and it does tend to have a little bit of blood with it. It's called the bloody show, appropriately named. If you didn't know this was coming, you might be very bothered and concerned that something had passed from the woman's uterus that was not an infant. But again, you can just, usually when you have a woman get ready for emergency childbirth, you have several layers underneath them. So you can just kind of fold over a layer and just kind of move that to the side. It's not necessary to hold on to it. By hold on to it, I mean keep it. Okay, when the water will break. Most women think that their water is going to break in a grocery store, and I don't know why. I think that's from TV. But no, most women, they have to have their amniotic sac broken at the hospital. And but on an emergency scene, you would not break the amniotic sac. It will happen naturally during delivery, even if it hasn't already broken. And just to be clear, just again, if you know it's normal, then you don't panic. So that's why I'm telling you some of the grosser details. And that is that the water is not water. It's a yellowish fluid. Sometimes if the baby has pooped prior to delivery, it's kind of got this green stuff in it, so it's kind of a greeny fluid. It doesn't smell or look like water, and all of that's okay. All right, stage 2 is delivery of the fetus or the infant, and so this can take a different length of time for different women. Sometimes it can take hours, and sometimes it can take minutes. Usually the minutes one is someone who's had several children already. Right, so the one thing that's going to tell you whether or not the baby is coming and you will be assisting with an emergency childbirth is the appearance of the head in the vagina. And so you're not going to be measuring the cervix for dilation or effacement or anything like that. But if the woman says she feels a burning, stinging sensation and the urge to push, then you do need to check to see if the head is visible. And if the head is visible, the baby is being delivered. And there's no pushing, there's no stopping, there's no delay. You've got to be there. I don't recommend that you do this next thing on a stranger, but if there was a husband or partner there, they could massage the inside of the vaginal opening to reduce the risk of tearing. So the pelvis is made perfectly, and it helps to assist the child to rotate in the correct way as it's being born. It just kind of, as it passes through, it will turn it The pelvis will turn the infant, and then you'll get um, one shoulder at a time. The shoulders are the hardest part. The head hurts, but then the shoulders are the widest part. And once the shoulders are out, the rest of the baby should be delivered on the next big contraction and push. You can help to kind of move one shoulder down as to let the other one come in, and kind of angle them. But otherwise, there's no pushing and there's no pulling. Stage 3, so the infant has been delivered, and we'll talk about what you're supposed to do after the infant is delivered in a minute. But after the infant's delivered, there's still one more stage of delivery, and that's stage 3, and that's called the delivery of the placenta, which is also termed the afterbirth. The placenta is a reasonably good-sized, kind of looks like a jellyfish. It's attached to the other end of the umbilical cord, and it's also attached to the inside of the uterus, and it's where the blood supply is shared between the mother and the infant in the womb. And it naturally comes off the uterine wall after delivery, and all those little blood vessels clot, and then the placenta is delivered through the vagina, just like the infant, and the mucus plug. So this comes after the baby about 15-30 minutes. That does need to be saved so that the doctor at the hospital can check it for completeness, because if any piece of the placenta had basically stayed inside and didn't come out with the rest of the placenta, they would need to go get it so that it didn't start to decay and cause the woman to have an infection. And again, another thing that's normal that we don't see in the TV deliveries, we see, that's why I think everyone thinks their water is going to break and it's just going to be like clear water, because that's how you see it on TV. You also don't see a lot of blood on these deliveries on TV, but the truth is a woman loses a lot of blood during pregnancy, during delivery, about a half a liter, sometimes more. For light-skinned people, redheads, they tend to bleed a little bit more during delivery. So this is normal. Again, a woman has about 40% more blood by the end of pregnancy because of all the blood that's needed also for the infant. That this is not a critical blood loss unless it's too much. If it's more than a half liter, then we start to worry, definitely more than a liter, and you're starting to really worry. As the uterus starts, the bleeding will slow down in a normal delivery. One thing that can help is if the mother nurses the infant soon after delivery, it causes a release of oxytocin, which helps with the milk production and delivery, but that also causes the uterus to contract, and the uterus contracting will help to speed up the clotting and slow down and speed up how fast they stop bleeding. And so that would help to control the bleeding after delivery. Okay, some things that might cause a complication: a prolapse cord, meaning the cord is coming out ahead of the baby. Again, no pushing, no pulling, but you can put the mother on her hands, elbows, and knees. So like where they're on their elbows and knees with their head down and their rear up higher than their head. And that takes some of the pressure off of the cord so that the baby's still getting the blood supply that it needs. Breech. So again, you're not turning the infant, so it's coming out feet first, and you're going to have to let it try to be delivered that way. If the head does not follow the body within 3 minutes, so the body's delivered, but the head is not, you can put 2 fingers in the shape of a V inside the vagina, and so basically you're holding the vagina wall away from the baby's mouth with that V. Those 2 fingers, and this allows the baby to get air if it's trying to breathe. All right, so treatment. Of course, you've called 911 and asked for an ambulance, and they may ask you some questions, and you can just answer those questions as they ask. They will probably ask how far along the woman is, if she has any signs like has her water broken, had the mucus plug come out, is it her first pregnancy, are there any complications, is it multiples, and how much time between contractions. And then the last thing, which tells you how much time they have, and that is their crowning, is the head visible in the vagina. And if the head is visible at the vagina, they better hurry. All right, so you can prep the mother, have several layers, like I said, underneath her blanket, and then if you had newspaper or something, several layers of that, so that anything that did come out that you just want to move aside, you could just fold those layers out of the way. Having the woman breathe slowly and panting and trying to get through the pain of the contractions is, you can just do your best. Hopefully they've had some kind of pregnancy class where they know about the different types of breathing methods for dealing with the pain and the contractions. All right, you probably won't have a bulb syringe, but try to find some gauze that you can help wipe out the baby's mouth after it's delivered, because it will be covered in kind of this mucus. And so you want to wipe that out of the baby's mouth and nose. If you had a bulb syringe, that's how they do it at the hospital. If you had a plastic bag to save the placenta, but again, I would just roll it into that layer of newspaper that you have under the mother and set it aside. String or shoelaces, so you'll need 2 for tying off the umbilical cord, and a blanket or towel or something, sweatshirt, anything to keep the baby warm. And then we'd like another blanket to go over the mother after she's delivered to help reduce the risk of shock. All right, again, we guide, we don't pull, we don't push, just there basically to make sure nothing goes terribly wrong and to catch the baby. All right, you can check the neck for the cord, but do not pull on it. If it's tight, you cannot pull, again, no pulling on the cord, because the cord is attached to the placenta. And you pull on the cord, you pull on the placenta, it might tear off the uterine wall, which could cause a critical amount of bleeding if you do that. So don't pull. If it is loose enough, you can slip it over the head to get it off the neck, but only if it's loose enough, and then help guide one shoulder at a time. It does say to put light pressure on the head, have the mother push slowly. Again, this just reduces her risk of tearing. It doesn't, wouldn't want to delay this too long. The head does need to be delivered. Just if you can slow it a little bit and have the mother deliver the head slowly, maybe with 2 different contractions instead of just one, that could reduce the risk of her tearing, but not longer than that. All right, once the baby's out, wipe the mouth and nose with the gauze, tie off the umbilical cord in 2 places, and then keep the baby warm. Encourage the mother to nurse, and this will decrease the bleeding as well as calm the baby. Okay, APGAR score. So you're not going to take an actual number down because I'm not expecting you to memorize this, but do take note of some things. The appearance of the skin, is it pink or blue? Do they have a pulse? Is it strong? Is there a reflex and grimace when you're clearing the airway with the gauze? How active and what's their muscle tone like? Are they limp? Are they active and kicking? And respiration, none weak or strong. So after the baby's born, it takes a little bit of time, not long, for the baby to start to breathe. And as soon as they start to breathe, they usually start to cry. So it's been quite an ordeal. But it's okay too if the baby comes out and at first it appears, blue and limp and very weak pulse and no reflex and not breathing, and then within 30 seconds or so it starts to breathe on its own and all of that improves and it pinks up and starts getting mad. That's really what you want. We want that bright red, screaming, kicking, pissed off little baby. Yelling means they're really strong in respiration, and so that's great. So it's when you hear those sounds, that's a good sign. All right, save the afterbirth, the placenta so the doctor can check it, have the mother rest. We don't elevate the legs in this case. We just let the legs come together and put a blanket over her to help prevent her from going into shock. It does say to massage this on the lower abdomen to help pass any blood clots. Again, I would let, if there was a spouse or a spouse with them, not a spouse necessarily, but a partner, the father, whatever, to let them do it. It is painful. It does help to move those blood clots out, but it is a little bit painful and probably something I would have the partner do instead of doing myself. Again, it's not life-threatening, so I wouldn't do that. All right, so this is a perfect time in the semester to have this lecture. Some of you just listened to that and went, I am so not ready for that. I promise you that when you are ready, people say this is the most wonderful moment in their lives, but if you are not ready, it's always a good motivator to just focus on your studies, because I think you guys all know how this happens. So focus on your studies, and someday, I promise you will be ready. Well, I can't promise that, but hopefully you will be ready, and it will be a wonderful moment.